Bismillahirrahmanirrahim and Assalamu alaikum to all. This is Sayyid Abrar Ahmad and you are watching third live episode of Endocrine Training Forum on Diabetes TV. We will start today's session with the name of Allah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانهر إن شانئك هو الأبتر صدق الله العظيم. Jazakallah. Before going to the introduction of our session chair and presenter, I just highlight the important central idea of Endocrine Training Forum. The objective of Endocrine Training Forum is the facilitating and grooming diabetes healthcare leaders by experts. The topics of our today's session would be, inshallah, approach to a patient with short stitch, approach to a patient with hypercalcemia, and updates in diabetes. So now it's time for the introduction of our respected session chair and presenters. The introduction of our session chair, he is experienced chairperson with a demonstrated history of working in the hospital and healthcare industry. He is skilled in diabetes, clinical research, medical education, epidemiology, and diabetes management. He is previously associated with the Senior Registrar of Royal Derby Hospital, London, member of American Diabetes Association, and member of European Society of Endocrinology, member of American Association of Clinical Endocrinologists. He is also examiner of FCPS, Internal Medicine, CPSP Pakistan, examiner of FCPS Endocrinology, CPSP Pakistan. He is also the examiner of PACES, Royal Colleges of Physicians and Surgeons, UK. He has a special interest in medicine and endocrinology. He is currently working as a professor of medicine and head of Department of Internal Medicine, Endocrinology, Diabetes, Shaheed Zulfikar Ali Bhutto Medical University, Pakistan Institute of Medical Sciences. Yes, he is Professor Dr. Rauf Niazi. Please welcome our today's session chair, Professor Dr. Rauf Niazi. Sir, thank you so very much कि आपने अपने important time में से आज तमाम healthcare professionals के लिए time दिया. So moving towards our first presenter and moderator. He is associated with Pakistan Institute of Medical Sciences in multiple capacities since 2008. Consultant physician and director medical affairs at Shifa International Hospital from 2015 to 17. He is graduated from Foundation University Medical College. He is MRCP Medicine from Royal College of Physicians, UK. FCPS Medicine from College of Physicians and Surgeons. FRCP Royal College of Physicians from Edinburgh, UK. Member European Society of Endocrinology, member American Association of Clinical Endocrinologists, and is a special interest in endocrinology and diabetes. Yes, he is currently working as assistant professor of medicine and consultant physician, Department of Internal Medicine, Shaheed Zulfikar Ali Bhutto Medical University, Pakistan Institute of Medical Sciences. Yes, he is Dr. Mohammad Ali Arif. Please welcome our first presenter and the moderator from throughout the session of Endocrine Training from Dr. Mohammad Ali Arif. Thank you so very much, sir, for being with us. Our second presenter, she is associated with Pakistan Institute of Medical Sciences, Islamabad since 2004. She is SCE in Diabetes and Endocrinology from UK, MRCP Medicine from Royal College of Physicians, UK, FCPS Medicine from College of Physicians and Surgeons, FRCP College of Physicians from UK. Yes, her special interest is in diabetes and endocrinology. She is currently working as an assistant professor of medicine, Department of Internal Medicine, Shaheed Zulfikar Ali Bhutto Medical University, Pakistan Institute of Medical Sciences. Yes, she is Dr. Fiba Sayed. Madam, thank you so very much for your kind time कि आपने important time में से आज हमारे तमाम healthcare professional के लिए काम दिया. So moving towards our first presentation and our today's moderator, Dr. Mohammad Ali Arif. Sir, please.
Unmute. इसको जरा मिनिमाइज कर दीजिए. मैं आपको पहले वो कर दूं. आवाज आ रही है?
Yes, sir.
Thank you, Abrar, for a very rousing welcome indeed. It's an honor and a privilege to be starting this session of the Endocrine Training Forum. Just at the outset, I want to remind our participants about a few ground rules before we formally start. We're going to be having 3 sessions, as you rightly mentioned: short stature, hypercalcemia, and updates in diabetes. What we'd like to do so that we can get maximum audience participation as well is that any questions that may be asked by the audience could be popped up in the chat box in the meanwhile. And at the end of all 3 presentations, we'll try to have an interactive Q&A session. So if any of our participants have any questions particularly, we can take them up down the line. We'll be starting just within a couple of minutes. We're having some screen sharing related issues by the looks of it. Right. इसको जरा minimize कर दो, okay? और right, Bismillahir Rahmanir Rahim. So we're going to be opening today with short stature, what you need to know. So at the outset, a question that comes to mind is, what really is short stature? And in all honesty, I'm so sorry, just give me a second. So who would you label as having short stature? A height below the 3rd centile or less than 2 standard deviations below the median height for that age and sex according to the population standard. Therefore, don't compare yourselves unnecessarily with our Caucasian counterparts. Our focus is essentially for our own population. Or even if the height is within the normal percentile, but the growth velocity is consistently below the 25th percentile over 6 to 12 months of observation. So what are the implications? What's our understanding? Approximately 3% of children in any population will be short. And approximately half of these will be physiological, that's familial or constitutional, and half will have what we call pathological short stature. So how tall can you actually be? If I'm aiming to be 6'2", is that actually possible? Genetics have a major role to play. There's an entity which we call the mean parental height, and it's the maximum height likely to be achieved depending upon what we've inherited from our parents. With regards to boys, mother's height and father's height divided by 2, and you add in 6.5 centimeters. With regards to girls, you take the mean of the parental height, that is the mother's height plus the father's height divided by 2, and you subtract 6.5 centimeters. There are lots of other formulas available, but this was the one I found to be the most easy to use and clinically applicable in your clinical practice. So what do you actually need to know? We mentioned 2 terms at the outset when we were talking about physiological short stature. These include constitutional delay or familial short stature. So what are the differences and what are the implications? With regards to familial short stature, as the name indicates, it means that generally speaking, the family members are already short. Both genders are equally affected. The height, rather the length measured of the child at birth tends to be normal. Both parents tend to have a short stature. The height velocity tends to be normal. Puberty is achieved on time, it's normal. With regards to bone age and chronological age, they tend to be equal, and they tend to be slightly greater than what the height age is. The final height is short, but it's normal as compared to the target height that you've anticipated after calculating mean parental height. With regards to constitutional short stature, that technically means you'll catch up eventually. It tends to be more common in boys. The height at birth is normal, but it starts falling. And there's a family history of delayed puberty. Parents tend to be of an average height. The height velocity is normal. Puberty tends to be delayed. The chronological age is more than the bone age, which is equivalent to the height age, and the final height tends to be normal. So let's put the causes in perspective. What can lead to short stature? It can be proportionate or disproportionate. So at the outset, let's talk a little bit about disproportionate short stature. You can either have short limbs or you can have a short trunk. With short limbs, the entities that can cause short stature include achondroplasia, chondrodysplasia, osteogenesis imperfecta, refractory rickets. And with a short trunk, you can think about spondyloepiphyseal dysplasia, mucolipoidosis, mucopolysaccharidosis, or a caries spine. We need to remember, obviously, these entities tend to be generally rare, but knowing them would allow you to identify them at the right point in time. Proportionate short stature, which as a clinician dealing predominantly in an adult population is something that you're more likely to see, would include normal variants. We've just mentioned them: familial short stature and constitutional delay. There can be prenatal and postnatal causes or endocrine causes, which will be more relevant to this forum. With regards to proportionate short stature, we've already mentioned familial and constitutional delay. In prenatal causes, intrauterine growth retardation tops the list. There can be a presence of intrauterine infections or a variety of genetic disorders. With regards to postnatal causes, undernutrition, chronic systemic illnesses, and even emotional deprivation can lead to short stature. The list of endocrine causes obviously is our focus of interest: growth hormone deficiency or insensitivity, hypothyroidism, juvenile diabetes mellitus, Cushing syndrome, pseudohyperparathyroidism, or precocious or delayed puberty. Now, after a theoretical review, let's try to put things into clinical practice. What do you need to do at the outset? Just 1 second, please. Hassan? बार-बार ये ऊपर से नीचे आ रहा है, and it's very annoying. I'm sorry, there's a small little technical thing. Thank you so very much. So what you need to do at the outset. Right. Once again, sorry, a few technical delays in between. We just got things running once again. So first things first, obtain the original birth records to document the length, weight, and fronto-occipital circumference of the child in question at birth. Mind you, when he comes to see you, he might already be an adolescent, but you do need to know how things were at the outset of illness. Thereafter, how tall are the parents? Assessing the height of both parents is absolutely essential. We've already mentioned documenting mean parental height and assessing the genetic potential of the individual in question. What height are they liable to achieve? Calculate the genetic potential via the mean parental height, and we have to ask about pubertal timings in first-degree relatives. With regards to the mother, ask about the age of onset of menarche. That's something that they're liable to remember, and the age of adult height attainment in the father. So a good history is going to tell you a lot with regards to what's the likely cause, helping us to trace the etiology. So with regards to the gastrointestinal symptoms, any history of diarrhea, flatulence, or borborygmy could indicate malabsorption. Vomiting can suggest an eating disorder or a CNS disorder, for example, a dysgerminoma. You need to consider dietary intake and composition with regards to substances ingested. Abdominal pain or discomfort could give you a clue with regards to inflammatory bowel disease. With regards to the heart, the presence of peripheral edema, cardiac murmurs, or cyanosis could give you an idea about congenital heart disease. Chronic infections or potential immune deficiency is another possible cause, which could be highlighted by poor wound healing, opportunistic infections. With regards to the lungs, the presence of sleep apnea, steroid-treated asthma, or cystic fibrosis could also lead to growth deficiencies. Neurologically, visual field defects could give you an idea with regards to pituitary neoplasms. The presence of vomiting is something you'd like to consider. Early morning nausea and polyuria and polydipsia could all be hinting towards neurological causes. With regards to the kidney, the presence of chronic kidney disease, and once again, polyuria, polydipsia is a cause for concern. And with regards to a social history, a history of anorexia nervosa or bulimia or emotional deprivation could also contribute to short stature. So if I were to summarize history-based clues, if there's history of delayed puberty in parents, you can think about constitutional delay. If there's low birth weight, think about small for gestational age. If there's neonatal hypoglycemia, jaundice, or a micropenis, you can think about growth hormone deficiency. If there's a history of poor dietary intake, think about undernutrition or malnutrition. You could think about a pituitary or hypothalamic space-occupying lesion if there's a history of headache, vomiting, or visual problems. Lethargy, constipation, or weight gain could hint towards hypothyroidism. And polyuria could make you think about chronic kidney disease or renal tubular acidosis. Furthermore, there are a few pointers which you need to take into account: midline defects, micropenis, frontal bossing, depressed nasal bridges, or crowded teeth. You can think about growth hormone deficiency. If there's a history of rickets, think about renal failure, renal tubular acidosis, or malabsorption. If the patient's pale, thought of renal failure, malabsorption, or nutritional anemia come to mind. If there's an evidence of malnutrition, you could think about malabsorption or celiac disease. If the patient seems to be obese, think about hypothyroidism, Cushing syndrome, or the Prader-Willi syndrome. If you see metacarpal shortening, you can think about Turner's or pseudo-hyperparathyroidism. The presence of a cardiac murmur could make you think about congenital heart disease or Turner syndrome. And if there's mental retardation, think about hypothyroidism, Down syndrome, Turner syndrome, or once again, pseudo-hyperparathyroidism. With regards to the physical examination, there are a few things you shouldn't miss at all. Measure the height and weight, palpate the thyroid gland, assess a patient's visual fields, check the mucous membranes for ulcerative stomatitis, which could give you hints about either malabsorption or inflammatory bowel disease. Do perform a genital examination and do assess for secondary sexual characteristics. Now, once you've labeled that a patient does seem to have short stature, you've done a clinical examination, you've taken a detailed history, how are you going to investigate your patient? I'm going to classify the investigations into non-specific tests and those tests for specific growth hormone deficiency. So there are quite a few non-specific tests to aid in diagnosis. Do a complete blood count for hematological abnormalities, do an ESR for chronic inflammation, get a celiac screen in the form of anti-TTG antibodies, do a thyroid function, and estimate free T4 levels if you're suspecting TSS deficiency, TRH deficiency, or thyroid binding globulin deficiency. And measure electrolytes for renal tubular acidosis. You can measure transferrin prealbumin for suspected undernutrition. Thereafter, you can move for specific tests, measure insulin-like growth factor 1 levels. You can measure IGF protein, binding protein 3 levels. You can do karyotyping for suspected Turner syndrome. And thereafter, you can do dynamic growth hormone measurements in response to insulin, levodopa, or arginine. You can also measure gonadotrophin levels in the form of FSH and LH. With regards to radiology, an X-ray for bone age becomes essential, and you can also do an MRI pituitary protocol if a pituitary mass lesion is suspected. So the X-ray for bone age, what are we going to gain from it particularly? Bone age gives us an idea as to what proportion of adult height has been achieved and what's the remaining potential. Bone age is delayed compared to chronological age in almost all cases of short stature, but it attains a degree of significance if the difference is plus minus 2 years as compared to chronological age. A few words about dynamic testing for growth hormone deficiency. At the outset, we have something which we call the insulin tolerance test. In the insulin tolerance test, insulin is administered IV at a dose of 0.1 units per kg at time 0 to produce a lowering of plasma glucose levels to less than 40. As the idea behind it is that your growth hormone is also a stress hormone. Inducing hypoglycemia should lead to a physiological rise in growth hormone levels. Glucose levels are monitored by capillary samples every 15 minutes and until symptoms of hypoglycemia develop. Serum glucose and serum growth hormone levels are measured at 0, 15, 30, 60, 90, and 120 minutes after administering insulin. And you can diagnose growth hormone deficiency if a peak growth hormone level is less than 5.1 microgram per liter. Mind you, this is obviously a relatively invasive test. You are going to be inducing symptomatic hypoglycemia, and you would require very close monitoring in any patient that you decide to get this done for. Another test that you can do, which is slightly less invasive, is the levodopa propranolol test for growth hormone deficiency. So levodopa is a dopamine receptor agonist, which stimulates the release of growth hormone. Dopamine is involved in the stimulation of growth hormone release, and in the converse, beta-adrenergic control negatively regulates growth hormone. So the theory behind it is you give a dose of propranolol first for beta blockade in the system, and thereafter you're going to be trying to stimulate growth hormone release by using levodopa. So propranolol is administered at 0.75 to 1 milligram per kg orally prior to levodopa. The dose of levodopa tends to be weight-based. In individuals less than 15 kg, it's 125 milligram. Between 15 to 30, you double the dose to 250, and beyond 30, you double the dose further to 500. Blood samples for growth hormone testing are drawn at 0, 60, and 90 minutes after the administration of levodopa. And if your growth hormone still doesn't peak beyond 5.1, you can diagnose growth hormone deficiency. A commonly encountered question in clinical practice is, how are you going to replace growth hormone if you've diagnosed growth hormone deficiency? The initial dose is 0.16 to 0.24 milligram per kg per week. That translates as 22 to 35 microgram per kg per day. And thereafter, you'll individualize. You measure serum IGF-1 levels as a tool to monitor adherence and IGF-1 production in response to growth hormone changes. Guidelines do tend to recommend different target IGF-1 levels, but currently you're recommended to go roughly about 80% of the reference range, and some guidelines recommend further beyond. So summarizing, short stature can present a diagnostic challenge. Assess the general genetic potential of the patient, measure mean parental height and growth velocity, examine for the possible causes of short stature, measure the bone age via X-ray. If the bone age is plus minus 2 years of chronological age, you might need to consider intervention. Order investigations as guided by your clinical findings and the index of suspicion. Document and assess for growth hormone deficiency prior to commencing either growth hormone replacement or IGF-1 replacement therapy. And that'll be me signing off. For now, I'll be handing over the session to my colleague, Dr. Fibasei. Approach to a patient with hypercalcemia. Stay tuned. It's going to be a lovely talk. Thank you so very much indeed.
This one?
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Ali. That was a wonderful talk, kept us engaged throughout. So the next part of this session is going to be approach to a patient with hypercalcemia. And I'm going to try to make this very simple so that by the end of this session, you're able to tackle any patient who presents to you with hypercalcemia. Okay, so let's begin with the words of Benjamin Franklin. An investment in knowledge pays the best interest. Okay, this is how we're going to go about this talk. We'll talk a bit about some physiology basics, etiology of hypercalcemia. We'll be dealing with approach to a patient with hypercalcemia, and then a few words about the management of hypercalcemia. So, any guesses on this gentleman? This is Sir Humphrey Davy, who was the first person who in 1808 actually managed to separate calcium from a mixture of calcium and magnesium oxide. The word calcium comes from the Latin word calx, which means lime. So this is the daily calcium balance in a typical adult. And you can see that there's a very tightly regulated mechanism which keeps the extracellular fluid calcium at 900 milligrams. The major store for calcium is the bones, which has around 1 kilogram of calcium. And every day there is an accretion, exchange, or resorption of 600 milligrams. The intracellular fluid calcium is 9,000 milligrams. But the dynamics basically occur in the GI tract and the kidney. So a typical diet mostly contains 1,000 milligrams of calcium. There is secretion of 300 milligrams of calcium into the GI tract and an absorption of 400 milligrams. So a net 100 milligrams is reabsorbed and 900 milligrams is passed out into the feces. Daily, around 10,000 milligrams of calcium is filtered into the kidneys and 9,900 is reabsorbed. So a net 100 milligrams is excreted into the urine. So you can see that there's a very, very tight, mechanism. So a result of which is that 100 milligrams is absorbed from the gut and 100 milligrams is lost from the kidneys. It is basically the extracellular fluid calcium that is responsible for hyper or hypocalcemia. And this calcium is divided into 3 parts, as you can see in the pie chart. 50% of calcium is the ionized calcium. And it is this ionized calcium which is actually the metabolically active calcium. 40% of the calcium is bound to protein, predominantly albumin. And 9% is complex to anions like citrate and phosphate. So when we get the total calcium done, we generally have to correct it for albumin. And the formula for correction is serum calcium plus 0.8 into 4 minus albumin. You can see where the 4 comes from, which is the protein-bound calcium. If you want to find out whether a patient is hypercalcemia or hypocalcemia, and the laboratory gives you the choice of getting the ionized calcium, that would be the most helpful. If that's not available, then you find out the total calcium along with the albumin, and then you correct it for the albumin. Just a few words about the calcium balance, which is very tightly regulated by the PTH and the vitamin D. So we know that there are 4 parathyroid glands, which are located behind the thyroid gland. Whenever the calcium levels fall, there is an increase in the PTH. This PTH is then going to act on the bones, causing calcium and phosphate resorption, leading to an increase in calcium. The PTH will also directly act on the kidneys through the distal convoluted tubule and the thick ascending limb of the loop of Henle, causing reabsorption of calcium and phosphate excretion. Indirectly, the PTH will also cause activation of 1-alpha hydroxylase, which will then convert the 25-hydroxyvitamin D to 1,25-hydroxyvitamin D, causing reabsorption of calcium and phosphorus from the gut. So we see here that PTH directly acts via the bone and the kidney, and indirectly only through vitamin D on the gut. Resultant effect is that the calcium is raised and the phosphate is low. If we talk about the converse, say hypercalcemia, any condition which causes hypercalcemia will cause both the PTH and vitamin D to be low. Now, this is a very important statement, because if PTH and vitamin D are not low in the presence of hypercalcemia, which means that either the PTH or vitamin D is normal or raised, it means that PTH and vitamin D are causative. And this is the basic gist behind the workup of any patient who presents to you with hypercalcemia. A few words about the vitamin D metabolism. So just beneath the skin, we have 7-dehydrocholesterol. This is acted upon by the UV light and gets converted into cholecalciferol. Most of the natural sources, which includes oily fish, maybe egg yolks, and organ meat, contains cholecalciferol, and supplemental food contains ergocalciferol. Both the cholecalciferol and the ergocalciferol are then acted upon by the 25-hydroxylase in the liver and get converted into 25-hydroxy-cholecalciferol or calcidiol. This will then be acted upon by 1-alpha hydroxylase in the kidney and get converted into 1,25-dihydroxy-cholecalciferol. The active form of vitamin D, all its impacts or effects are because of the 1,25-hydroxy-cholecalciferol or calcitriol. And if we're to find out the stores of vitamin D, we generally do the 25-hydroxy-cholecalciferol. So let's come on to a case discussion. And as we move along the case, we'll be tackling not only the causes, but also the steps in the workup of a patient presenting with hypercalcemia. So a 50-year-old man presents to the outpatient department with a history of vague epigastric pain, generalized body aches, and constipation for the last several months. He has a history of hypertension and is regularly taking losartan and hydrochlorothiazide 50 by 12.5. His hypertension is well controlled and there is no other history of note. On examination, he looks apprehensive. He has normal vital signs. The abdominal examination reveals grade 1 tenderness in the epigastric area, and there is no visceromegaly. The rest of the CNS, CVS, musculoskeletal, and respiratory examination is unremarkable. So, what are the differential diagnoses? A 50-year-old man with generalized aches and pains, lethargy, fatigue, apprehensive, mild abdominal tenderness. Could he have hypercalcemia? What about metabolic bone disease, multiple myeloma, or malignancy with metastasis? So what investigations are you going to perform and why? Initially, we will be obviously starting with a complete picture blood, followed by the liver function tests, the renal function tests, calcium, phosphate, and albumin. So the WBC count is 5,500, which is normal. Hemoglobin is 15, which is normal again. Platelets are 200,000, normal. The ESR is 60, although the man is 50 years of age, and even if we correct for age, we find out that the ESR is raised. The ALT is normal, as is the alkaline phosphatase. The RFT is normal. The calcium is 11.3, with the albumin being 3.5. And if we correct it using the formula, total calcium, serum calcium plus 0.8 into 4 minus albumin, we get around 11.7, which we see is more than 1 milligram raised above the upper normal. The phosphate is low normal. So just a few points to ponder. What precautions do you require when taking a sample for calcium, phosphate, and albumin? Generally, we know that we send fasting samples, and this fasting is required more for the phosphate than for the calcium. We make sure that tourniquet is not tied because that can cause relative dehydration, leading to a falsely raised albumin and again affecting the total calcium levels. Whenever we do get a reading of hypercalcemia, it's mandatory to confirm it one more time before we go on to the workup. Why is the calcium corrected? As already mentioned, it is affected by albumin binding, and we have to correct it for the total albumin. And why does our patient have hypercalcemia? So let's go on from here. Let's have a discussion on the major causes of hypercalcemia. We know that there are a lot of mnemonics for remembering the causes of hypercalcemia, but generally I find this classification not only the easiest, but also it helps you in the workup of the patient. So we talk about endocrine causes associated with hypercalcemia, which might be because of excess PTH production or without excess PTH production. Excess PTH production might be syndromic or non-syndromic. So when it's non-syndromic, it might be because of primary hyperparathyroidism or because of parathyroid adenoma. Syndromic would include conditions like MEN1, MEN2, hyperparathyroid jaw tumor syndrome, some cases of familial hypocalciuric hypercalcemia. Endocrine causes without excess PTH production would include things like thyrotoxicosis, Edison's disease, VIPoma or pheochromocytoma, which directly have an impact on the bone without PTH excess and will lead to hypercalcemia. The second is malignancy-associated hypercalcemia. So malignancy-associated hypercalcemia is a cause of 90% of hypercalcemia in patients admitted to the hospital. This might be because of elevated PTH-RP, which occurs mostly in solid organ malignancies like breast, lung, ovarian tumors, conditions like non-Hodgkin's lymphoma, CML, CLL, and secondly, malignancy-associated hypercalcemia with elevation of other systemic factors like Hodgkin's disease, in which 125 dihydroxyvitamin D is raised, or myeloma, in which you have raised cytokines like interleukin-1, interleukin-6, and TNF. Third is the inflammatory disorders causing hypercalcemia, again, because of the macrophages and the monocytes producing activated vitamin D, leading to hypercalcemia. This would include conditions like berylliosis, silicosis, sarcoidosis, tuberculosis, Wagner's, and HIV. Again, the age of the patient becomes important when we talk about pediatric syndromes like Williams syndrome or idiopathic infantile hypercalcemia. Medications are not to be forgotten. They include thiazide diuretics, like our patient was taking, lithium, vitamin D, vitamin A, estrogens and antiestrogens, theophyllenes, aluminum intoxication, and milk alkali syndrome. And lastly, immobilization, especially in the presence of conditions with increased bone turnover like Paget's disease. So this is an algorithm of the workup of patient who presents with hypercalcemia, and we're going to tackle both arms one by one. So the first step you do if a patient has hypercalcemia is determine the serum PTH. First, your left side. So the first step is determining the PTH. if the PTH is increased or normal. So remember, ideally when calcium is raised, the PTH should be low. If it's not low, it means that the PTH is causative. So if it's either normal or increased, we think of hyperparathyroidism or familial hypocalciuric hypercalcemia, or the patient might be on a drug like lithium. Again, the history would be evident here. Now, to differentiate between hyperparathyroidism or familial hypocalciuric hypercalcemia is mandatory, because the latter condition would not require surgery and just follow-up. And the first condition, that is hyperparathyroidism, would usually require surgery depending upon, again, the guidelines. So we differentiate the two by doing the urinary calcium. If it's increased more than 200, then it's primary hyperparathyroidism, or if it's reduced, that is less than 100, or the calcium creatinine clearance is less than 0.01, then it's familial hypocalciuric hypercalcemia. Again, we've got three variants of this condition depending upon the genetic mutation. So normally when the calcium is raised, the PTH should be low. And if the PTH is low, we then go on to determine the PTH-RP, that is the parathormone-related peptide. If the PTH-RP is raised, I'm taking you to the right side of the algorithm, then you work up for malignancy. I already enumerated the malignancies, but again, you will do a thorough examination as well as imaging. Most of hypercalcemia that is related to malignancy doesn't present with an occult malignancy. The malignancy will mostly be evident and mostly the patient will have metastasis. If the PTH-RP is normal, we then go on to determine 1,25-dihydroxycholecalciferol. If the 1,25-dihydroxycholecalciferol is raised, we will think of a lymphoma or a granulomatous disorder. And if it's normal, then we go on to determine the 25-hydroxyvitamin D. If the 25-hydroxyvitamin D is raised, we will think of conditions like intoxication. So please keep this algorithm in mind, because we're going to go on to the discussion of our case from here. So if we go back to our patient, who was the 50-year-old gentleman with vague aches and pains in several months, nothing much in the physical examination except for epigastric tenderness, hypercalcemia, low normal phosphate. Now, if in this patient the PTH is 60, which is normal, what is the differential? So remember, the PTH should be low. If it's not low, it means that PTH is causative. So again, we will differentiate between hyperparathyroidism and familial hypocalciuric hypercalcemia by doing the urinary calcium levels. Okay, so let's have a twist. If in the same patient, we do the PTH and the PTH is 5, which is low, what is the next step? So the next step is doing the PTH-RP. And if the PTH-RP is raised, we then work up the patient for malignancy. Okay, let's have a twist again. If the calcium is raised, the PTH is normal, the PTH-RP is normal, what is the next step? We then do 125-dihydroxyvitamin D levels. If these levels are raised, we think of granulomatous disorders, and if they're normal, we then do 25-hydroxyvitamin D. And if the 25-hydroxyvitamin D is raised, we think of conditions which cause intoxication. Okay, so coming back to our patient, what if both 25-hydroxyvitamin D and 125-dihydroxyvitamin D are normal? What next? So this leaves us with very few conditions, the top of the list of which is multiple myeloma, which will cause hypercalcemia through mechanisms involving interleukins and TNF. This is an algorithm of a patient present hypercalcemia in a nutshell. It would be helpful to have a screenshot of this image, because it will walk you through the management and the workup of a patient who presents with hypercalcemia. So just a few words about the management of hypercalcemia. Hypercalcemia is divided into mild, moderate, or severe hypercalcemia. Mild hypercalcemia is 10 to 12 milligrams per deciliter, moderate is from 12 to 14, and severe is more than 14. A patient who presents with mild hypercalcemia is usually asymptomatic, and all you require is avoiding medications causing hypercalcemia, avoiding a high calcium diet, making sure that the patient is volume repleted, and you work the patient. A patient presenting with moderate hypercalcemia, if asymptomatic, you will continue with the same measures, but if symptomatic, you will then hydrate the patient with 300 ml of normal saline per hour. And you give the patient bisphosphonates, which might include alendronate, pamidronate, or zoledronic acid. Now, bisphosphonates generally start their action in 4 days' time, but the effect lasts for around 4 to 8 weeks. In patients presenting with severe hypercalcemia, not only will you hydrate the patient at the rate mentioned above, making sure obviously that if the patient has renal impairment or underlying ischemic heart disease, you will adjust the fluid replacement accordingly. You will give the patient bisphosphonate. What helps in this condition is calcitonin, because calcitonin brings down the calcium acutely. It will bring down the calcium levels in around 4 to 6 hours, given at a dose of 4 to 8 international units per kilogram intramuscular or subcutaneous twice a day. But the results do not extend beyond 48 hours because of tachyphylaxis. Furosemide can be instituted after the hydration has been normalized because it causes calciuresis. And we can use steroids in certain conditions like myeloma or lymphomas or intoxications, and calcium mimetics like Sansepar, which becomes especially important in patients who present with parathyroid malignancies. And if the patient has refractory or severe hypercalcemia of more than 18, we then plan for urgent parathyroidectomy, give denosumab, or use hemodialysis. I would like to conclude with words from George Bernard Shaw: "The reasonable man adapts himself to the world. The unreasonable man persists to adapt the world to himself. Therefore, all progress depends on the unreasonable man." Thank you very much. This brings me to the end of my session, and I will now be handing the forum back to Dr. Ali, who will be talking about the updates in diabetes. Thank you very much.
Right, we're just waiting until the slide deck gets set up in the meanwhile. Right. At the outset, before I start, let me extend my thanks to Dr. Fibber for really clearing out concepts. It was really, really clear, and I think I haven't understood hypercalcemia so well ever since I read over it the first time round. So for all of you who were listening, it was an amazing session. And now we're going to move on to the final leg of today's program, and that's going to be debunking diabetes. We're going to try to make sense of the guidelines. Now, usually every year or so, all diabetes societies, be it the ADA, the EASD, or the American Association of Clinical Endocrinologists, end up giving us a whole new list of things to follow. So I've tried this time around to simplify things and put things forward for you so that we can actually understand what they're trying to say. Sorry, the screen's gotten suddenly hung up for a moment. We'll be with you as soon as things start going forward. Right, I think we're going to be able to move on now. We're going to talk about some of the pearls from the ACE 2020 executive summary. What are the aims? Now, at the outset, just to remind ourselves, progressive pancreatic beta cell defect drives the deterioration of metabolic control over the course of time. It begins early and might be present before the diagnosis of type 2 diabetes is actually made. So you need good glycemic control to reduce microvascular complications. And obesity and prediabetes are underlying risk factors for the development of type 2 diabetes and the associated macrovascular complications. So every algorithm starts with lifestyle management, but the question is lifestyle management versus pharmacotherapy. Lifestyle management is imperative, but here I'd like to mention it shouldn't be the sole strategy. Pharmacotherapy is considered as an adjunct, a failure of lifestyle modification. Back in the day, in previous algorithms, you had a starting with lifestyle modification and then moving on to pharmacotherapy. That's a thing of the past. Do not delay pharmacotherapy and simply focus on lifestyle alone. Assess each patient based chronic disease. That's A, B, C, D. So with regards to weight considerations, we need to act now. Adiposity-based chronic disease is a chronic illness and long therapy is necessary. To diabetes and its complications are generally more expensive and they carry a greater risk. So act sooner rather than later. So defining our targets, we need to individually share screen. My apologies for the sudden loss of connectivity. Professor Niazi saying he can't hear anything. Can you hear us now, sir? Lovely. Thank you, sir, once again. It's great to see you as well, finally. We didn't have the visuals before, so we'll move on from here. Right, so what's the optimum HbA1c? As I mentioned, less than 6.5 is considered optimum if it can be achieved in a safe and affordable manner. You may think about higher targets for certain individuals, and your targets may change over the course of time. Now, a very important thing which I like to mention, how long should it take to achieve the target? Sooner rather than later is the take-home message, and combination therapy is usually required and should involve agents with mechanisms of complementary action. The statement that you start, you wait for 3 months, then you up-titrate, then you wait for another 3 months, then you up-titrate, that is doomed to failure. Sensibility from the ACE executive summary is aim to achieve your targets as soon as possible and consider combination therapy. You will still see prescriptions of high HbA1cs receiving metformin 250 milligrams twice daily. That's suicidal and a recipe for disaster. Please don't do that in your clinical practice. So yes, you need to take into account patient-based considerations, but at this point in time, consider cost versus value. The choice of therapy should include the ease of use and affordability. The therapeutic regimen should be as simple as possible to optimize patient adherence. The initial acquisition cost of medication is only part of the total cost of care, which includes the need for monitoring, risks of hypoglycemia, weight gain, and future complication management. And safety and efficacy should be given a higher priority than the medication acquisition cost alone. The take home is don't choose a drug just because it's cheap. What a patient might be saving right now, he'll end up spending on hospitalization costs, costs from loss of work, amputation risks. So just opting for a medication because it's been there forever and is cheap, you're not doing justice to your patient under any circumstances. So practical implications, how can we change our mindsets? Let's talk a bit about prediabetes. Lifestyle therapy with medically assisted weight loss is recommended. This can include medications, for example, using liraglutide, lorcaserin, phentermine to pyramate combinations, or even bariatric surgery if indicated. With regards to the pre-diabetes criteria, a sugar fasting of more than 100 or 2-hour post-OGTT more than 140. If one criteria is fulfilled, intensify the weight loss strategy, and you can think about adding. You've got an HbA1c in the pre-diabetic range, 5.7 to 6.4. You have any one of the pre-diabetic criteria mentioned here on the screen in front of you. Intensify weight loss and consider adding a therapeutic option. If 2 criteria are fulfilled, please use medication in addition to weight loss. And the medication which has been recommended in the algorithm includes metformin or acarbose because they're low risk, but at the same point in time, because of probably the weight-related benefits, you can think of using a GLP-1 receptor analog. So let's try to make sense of the entire algorithm. Set the goal. An HbA1c of less than 6.5 for patients without serious concurrent illnesses and a low risk of hypoglycemia. If there's evidence of atherosclerotic coronary vascular disease or a risk of it, heart failure with a reduced ejection fraction, or chronic kidney disease, regardless of the HbA1c target, use an SGLT2 inhibitor or a GLP-1 receptor agonist. Get an HbA1c at the time of starting treatment. Use the HbA1c to guide your therapy. If the entry A1c is less than 7.5, you may consider monotherapy. If there's evidence of either a risk or presence of atherosclerotic coronary vascular disease, heart failure with reduced ejection fraction, or chronic kidney disease, use an SGLT2 inhibitor or a GLP-1 receptor agonist, even as monotherapy. The choice of medication will depend upon the potential benefits and the fewer adverse effects. If you are opting for sulfonylureas or thiazolidinediones, although I have no idea why you'd be opting for them, exercise caution. If the entry A1C is 7.5 to 9, I repeat, there's no role of monotherapy. Dual therapy should be commenced, and you can escalate to triple therapy within 3 months if your target is not achieved. Once again, the guidelines recommend if there's an evidence of HFrEF, CKD, a risk or presence of coronary vascular disease, you need to opt for an SGLT2 or GLP-1. Once again, the choice of medication will depend upon the potential benefits and limited adverse effects. If you are opting for sulfonylureas, basal insulin, or thiazolidinediones in this scenario, exercise caution. And if the A1C is more than 9, which quite frankly we do tend to encounter in clinical practice, and the patient has symptoms, there's weight loss, there's wasting, there's polyuria, polydipsia, polyphagia, you've got clinical symptoms, think about using insulin along with other agents. If there are no symptoms present, please use at least a triple drug combination and reassess after 3 months. And thereafter, if you don't have your targets within 3 months, add insulin therapy. As with the other entry-level HbA1cs, if there are compelling indications, use SGLT2s or GLP-1 receptor agonists to avail the potential benefits. A few words about insulinization. The use of a basal long-acting insulin is recommended. Basal insulin analogs are preferred over NPH insulin. Please, now this is another thing. You'll see a lot of patients who are receiving a basal insulin along with a sulfonylurea. This goes against the spirit of the guidelines. Discontinue sulfonylureas on starting basal insulin. There's absolutely no logic of using these two things concomitantly. This is the estimated total daily dose based upon the entry HbA1c. If the entry A1c was less than 8, start with 0.1 to 0.2 units per kg. And if the entry A1c was more than 8, start from 0.2 to 0.3 units per kg. Titrate the basal insulin dose every 2 to 3 days in an aim to achieve target glycemic control. As we already understand, diabetes is progressive. You will require intensification at some point in time. But how do you do it? If targets aren't achieved despite basal insulin, you can add a GLP-1 receptor agonist, an SGLT2 inhibitor, or a DPP-4 inhibitor if these drugs aren't already being used. Thereafter, you can consider basal +1, that's prandial cover before the largest meal, or you can intensify to the basal bolus. Pre-mixed analogs may also be considered as part of an intensification strategy. And with that, that'll be me signing off, and we'll now be moving to the next leg, which will be the Q&A session. That brings us to a conclusion here, and let's try to get the forum set up for taking your questions. I'd like to invite my colleague, Dr. Fibber, to take a seat with me over here. Now you can maximize the screen as well.
Being the chairperson of the session, I'd like to make a few comments before we go on to question answer session. I think these two, not only a handsome and a smart girl, but they did wonderful job. It was brilliant, to the point, excellent presentations. And I'm sure the audience must be booming with questions and ready to bombard them with a lot of questions. I have comments to make, but I'll leave it to the end. And for the time being, I'll let the audience put their questions forward. I don't think these two have left any space for many questions, but for the purpose of clarity, there might be questions, and I'll leave these two to answer, and I'll intervene wherever it is necessary to add on to something which I think won't be there much to say, right? So with these comments, I'll leave the podium to these two brilliant doctors.
Thank you, sir. With your permission, we'd like to start. Let me just take 1 second. So we've had a few questions in the chat box right now. I'd like to open with the first question, and I think we can have a healthy discussion on that as well. If a patient with disturbed lipid profile is there with a fatty liver, and then after some years develops type 2 diabetes, fasting sugars average between 129 to 129, 160 fasting between 129 to 160, random below 200. What is the relation between fatty liver and diabetes? That's the first part of this question. And what's the difference between the readings in a glucometer and blood obtained from veins from a lab, and which reading is more accurate? At this point in time.
Okay, thank you, Dr. Ali. So I think perhaps we needed a bit more information about the patient's weight, because it can be vice versa. When the diabetes was diagnosed, generally there's a very strong link between diabetes and a fatty liver, and even obesity, diabetes, and fatty liver. So generally, a lot of times we see that the three conditions go hand in hand. And again, we don't wait, we address the weight, we address the diabetes, we address the lipid profile, and generally the fatty liver tends to, at least many times, we see the liver enzymes going down. If we talk about the difference between the readings in the glucometer and the vein, obviously the venous sample is more accurate, but the difference is very little. So maybe 5 to 10 milligrams, which makes using a glucometer very, very accurate indeed. But if you ask me which is more accurate, it's going to be the venous sample. If you'd like to add on, maybe Sir would like to add on something.
With regards to the first scenario, as Dr. Fibber rightly pointed out, you haven't mentioned the patient's weight. There's an entity which we call the metabolic syndrome, in which you will have deranged lipid profiles, the patient will be overweight, blood pressures will be going up, neck circumference will go up, and you will have impaired glucose control. So in that situation, there is an overall link. And as Dr. Fibber rightly pointed out, all of these things are interlinked. You can't really have a cause and effect aspect here. It could work either way. With regards to glucometer measurements, remember, glucometers check for capillary blood glucose. And a venous sample, which you do in the lab, will give you venous blood glucose. The difference tends to be limited. Glucometers do have a small limitation with regards to a difference in the reading. But what we tend to advise our patients is, when you purchase a glucometer and you've checked your sample, send a sample to the lab at the same time concomitantly. Therefore, you can calibrate your glucometer. If there's a difference of, say, 5 to 10, you can either add it on or subtract it from your overall reading to get an idea of the situation. We'll move to the next question. Okay, I think the patient's weight has been, with regards to the first patient, once again, the weight was 55 kg and the height is 52 kg.
The age is 52. Again, we're more interested in not in the total weight, but in the BMI. So we need the height, but as I think we've already answered the question to a great extent. So if Sir would like to add on something.
So we have another question. Anti-hypoglycemic options in CLD. Can you hear us, sir? Professor Niazi, would you please unmute your mic? It's still muted.
I'm trying.
It came online and then it's gone again. Would you please unmute the mic and then speak? We value your input, sir.
Can't hear you.
Can't hear you, sir.
Now you can hear me, because the organizers had muted me somehow deliberately. I think wisely answered, and vast majority of patients tend to be obese and they are overweight, and we know about metabolic syndrome, but we do understand that there are physiological patients who are metabolically obese rather than being obese. So diabetes per se with a sedentary lifestyle also contributes to fatty liver. So a very poorly controlled diabetes in a patient who's leading sedentary lifestyle would also lead to a NAFLD situation. So in those patients, again, the same thing would apply. That would mean lifestyle modification, exercise, regular walk, and control of diabetes. So what I think that the question which was put up was pertaining to the role of diabetes. Yes, diabetes, when poorly controlled, in even a metabolically obese patient, that means who is not very overweight, he or she, even that can lead to a fatty liver. And regular exercise, that means walk, that does play its role in those patients. However, if you are overweight, then it is the weight which is causing the liver to get fatty. So one has to differentiate these entities from each other. So in a metabolically obese patient who is poorly controlled in diabetes, you intensify the diabetic control and you ask them for regular walk, and that would do wonders for them as well. So that's what I wanted to add to this, the question you answered rightly.
Thank you, sir. The next question from our audience is anti-hyperglycemic options in chronic liver disease. Dr. Hiba, your take?
So again, it depends upon the liver enzymes, but generally for metformin is safe. Glibenclamide can be safe.
Yeah.
And again, insulin is obviously safe. We have data on the use of SGLT2. It depends upon CLD, whether it's DCLD or just CLD. So for CLD, a lot of the newer drugs are actually safe if we monitor the liver enzymes. But if it's DCLD, then obviously the safest is insulin.
I would agree with Dr. Fibha there. It would essentially depend upon what your clinical presentation is. Guidelines tend to be a little bit more lenient now with regards to CKD and CLD. You have to see what your goal is, what's your essential target, what the patient's life expectancy is, what extent of glycemic control do I want to give, and what's the risk of hypoglycemia. In a patient with chronic liver disease, the risk of hypoglycemia goes up once again. So I'd be cautious in using a drug that's liable to precipitate hypoglycemia. Metformin, SGLT2 inhibitors, DPP4 inhibitors tend to be relatively safe and have a neutral hypoglycemic profile. However, if a patient has very labile blood sugars, then maybe shots of insulin would be a better option. You've got rapidly acting analogs which you can use, and you also need to keep in mind the patient's life expectancy and what your aim is for glycemic control.
I'm just adding on to that. I think as Dr. Ali said, perhaps an HbA1c that's not too tight. We need to avoid hypoglycemia, which can be more dangerous than hyperglycemia. And at the same time, glycemic variability. Again, that has a very strong link with mortality. So maybe not very tightly controlled blood sugars, but something that allows the patient to lead a relatively normal life. Again, that would depend upon whether it's CLD or DCLD. The scenario changes. If sir would like to say a few words about this.
Okay, we'll move to the next question with the permission of the chair. And that is, what are the criteria to start pharmacotherapy for pre-diabetics? I think I've covered that in part of the presentation, but I'll repeat that for you. They've given, the guidelines give you two cutoff values, a fasting blood sugar of more than 100 and a 2-hour post-OGTT of more than 140. If one criteria is fulfilled, then intensify the lifestyle modification and think about pharmacotherapy. If, however, two criteria are fulfilled, I'll make it even more simple. The patient has a fasting of more than 100 and a 2 hours post-OGTT of more than 140, start therapy. Don't wait.
Yep. And once again, if you're using just lifestyle modification and the pre-diabetes persists for 3 to 6 months, you're going to start the patient with pharmacotherapy. So it cannot just stay there forever. Pre-diabetes persisting for beyond 3 to 6 months on simple lifestyle modification will need pharmacotherapy.
We have a very nice, interesting question ahead. A 50-year-old patient having a 70 kg weight, diabetic for the last 23 years, is on long-acting insulin, 20 units at night, and thrice daily shots before meals. Still, the fasting is 200. Should we increase the dose of either insulin or add any oral anti-diabetic? If I may, Dr. Fibber?
Please go on.
Let's talk once again very briefly about the natural history of diabetes. When diabetes is diagnosed, 50% of the pancreatic beta cell is already gone. Thereafter, the rate of decline tends to be 3 to 5% per year. So in a vast majority of patients, 10 to 15 years of diabetes, you have essentially no pancreatic beta cell mass left. In a 50-year-old individual who's had diabetes for the last 23 years, I'm guessing they were diagnosed with diabetes at the age of around about 27. So we really don't know whether it was a type 1 diabetic or a type 2 diabetic, or maybe latent autoimmune diabetes of the adult. With regards to the clinical scenario that you've put forward, the patient is still under-basalized. If you can take a look at things, you have to titrate the basal insulin, aiming for a fasting control of around about, say, 100, if you're aiming for good control. The patient's only on 20 units of what I'm assuming is probably glargine. So please up-titrate every 2 to 3 days, aiming for a glycemic fasting control of around about 100. You haven't mentioned the other SMBGs, that's self-monitoring of blood glucose, or the HbA1c. So if you could add that up further, that would make things even clearer. Dr. Fibber, if you'd like to add something.
Just a bit more information. Thank you, Dr. Early. You answered it very well. So the patient has a weight of 70 kilograms. For most basal insulins, you should be able to go up to 0.5 units per kilogram. So for this patient, you can easily go up to 35 units minimum. And if you're going beyond 35 and there's still the glycemic control is suboptimal, then you're going to switch to premixes. So I think that should hopefully answer.
Since this patient's already on a basal bolus regimen,
yes, so
we just need to up-titrate the basal insulin, and God willing, inshallah, you will get good glycemic control.
And there is no upper limit of insulin. So
this is something Dr. Fibber's really rightly pointed out. A lot of patients have this concern as well. A lot of doctors have this concern as well, that I can't go beyond 100 units of insulin. That is absolutely not true. There's no upper limit cutoff. Everybody has different insulin requirement. The care that you need to take is that obviously when you increase a dose, you're going to increase the risk of hypoglycemia. So be cautious, cater according to a patient's need. And at the same time, with regards to prandial control, you can't forget the lifestyle aspect there. If an individual is gorging 4 to 5 rotis in one session, then obviously you are going to need to add further bolus control as well.
Can I request Professor Niazi for his comments, please?
I think you both wisely answered the question. It was under basal insulinization, which was causing all that. Are you able to hear me?
Yes, sir.
Yes,
loud and clear.
So the basal insulin needs to be increased, and that would obviously lead to control of the diabetes. With the modern drugs, with new modern drugs, like combinations of GLP-1 and a long-acting insulin, now the weight issues can be addressed as well. And lesser doses of basal insulin may be required, and you may use ultra rapidly short-acting insulins 3 or 4 times daily and get a very, very good control. But when you're using basal insulin, when ultra rapid acting insulin 3 times a day, for example, probably if the fasting is not coming right, rightly pointed out, it's the basal insulin which has not been adjusted properly. So if you up-titrate the basal insulin, the dose of rapidly acting insulins will come down, ultra short-acting insulins, and your fastings will get controlled. So that's the simple answer.
Thank you, sir. There's another question. Although it's been addressed to Sir, I'm going to hijack it very briefly and then give it back to Sir. If there are so many benefits of SGLT2 inhibitors, why should we not consider them first-line drug just before metformin? I would invite the participants to revisit the algorithm. There's no first-line drug. Metformin is not your first-line drug. You have an option to choose any agent from the list of drugs before you, decide according to the entry HbA1c, decide about the potential benefit, decide about the patient's overall conditions. If they're compelling indications, then SGLT2 inhibitors and GLP-1 receptor agonists do assume a first-line proportion. They should be considered first before any other drug if there is a risk or presence of atherosclerotic coronary vascular disease, heart failure with reduced ejection fraction, or chronic kidney disease. Metformin is not necessarily the first drug that you're going to be opting for. That's why the topic was debunking diabetes and understanding the guidelines. So please don't start with metformin 250 TDS. You have better options to consider. If you wish to use it, you can. You're free to opt from any drug in the FDA approved list, provided you've got your own reasoning and logic for that. Sir, I know I hijacked it, but I'm handing it back to you.
And then you answered it beautifully, and you put up the guidelines, the ACE guidelines, and they recommend it is according to the patient's condition. So rightly so, if I've got a patient with reduced ejection fraction, an overweight patient with CRF, other problems, why would I start metformin? I would go straight to SGLT2s, and they have a clear-cut benefit in this situation. So there is no first line. It's according to the patients. If I have an obese patient, maybe I'll combine both a GLP-1 analog with metformin. So combinations can be used, or a single drug can be used, and there's no first line treatment now, as you've debunked the load of diabetes. So it is basically no first line drug. It's according to the situation of the patient and the scenario, and obviously the patient's presentation.
Thank you, sir. Moving to our next question. In type 2 diabetes, there is insulin resistance. Receptors are not responding. Without diagnosing the insulin deficiency or not, we are trying to increase the production of insulin by different treatments of even insulin. Why problem is with receptors? There's a slight conceptual vagueness there, but Dr. Shiva, if you'd like to throw in a few comments.
I think I really don't understand the question.
Okay, let me try to rephrase it for the understanding of our audience as well. It's a commonly asked question that in diabetes, in type 2 diabetes, more often than not, there's a degree of hyperinsulinemia. There's already a lot of insulin in the body. And then why are we adding more insulin? Why are we adding things? I think that's what they're trying to ask.
So perhaps, yes, thank you for clarifying. So I think that's why the first line treatment is not insulin. The first line treatment is generally insulin sensitizers, which could be in the form of your metformin, it could be in the form of your SGLT2, it can be in the form of your GLP-1. So it's not really insulin. It's only after we've used this insulin sensitizing drugs that we go on to the use of insulin. So it's actually both mechanisms. There is insulin resistance, and later on, there's also insulin deficiency. So it's a two-pronged approach, and it has to be tackled in the same way. And again, we must not forget that there are a number of adults, around 10%, who actually present with LADA. So at the time of diagnosis, they might actually be type 1, which gets diagnosed late, and they will only respond to insulin. So we have to keep a broader differential in mind, look at the patient, whether the patient is obese, metabolically obese, if there's a history of type 2 diabetes, not forget about LADAs or MODI, and then according to the type of diabetes, we address and treat the patient.
A few things, if I may add, Dr. Fibber, thank you for clearing that out. Back in the day, the thought process with regards to diabetes was just the pancreatic beta cell. Yes, obviously insulin resistance has a major role to play, but let's think about other pathophysiological components as well. There's hyperglucogonemia, there's alpha cell hyperactivity, there's a defect in your incretin effect, there's a defect in gut hormones, there's leptin related issues as well. So now the term is the ominous octet. There have been more than 8 pathological mechanisms that have been identified in the pathophysiology of type 2 diabetes. Yes, insulin resistance is a major driver. And Dr. Fibber rightly pointed out, you can use drugs to sensitize the body to the insulin. You're aiming for drugs that can cause a degree of weight loss, and you can attack the other issues that are occurring other than the insulin resistance. Now, another thing that you need to realize is when there's resistance, for example, you want to push down a wall and somehow you're going to manage, you can add more force. Sometimes the body is already hyperinsulinemic, but it's still not working. Therefore, adding further insulin can help overcome that resistance to a certain degree as well. But as Dr. Fibber rightly pointed out there, it's not necessarily going to be the first modality that you're going to opt for. You have a variety of drugs. You've got a huge armamentarium to choose from a multi-pronged approach, a multifaceted approach, out of which insulin therapy, or for example, secretagogues, sulfonylureas, etc., can also be used if the condition mandates as such. Professor Niazi, could we have your take as well?
You two are doing such a beautiful job that I don't need to add anything. But wherever I feel there is deficiency, I'll definitely pitch in. But I think you beautifully highlighted, there are a lot of mechanisms. People are talking about ghrelins, people are talking about resistin, people are talking about multiple factors, and not just pure insulin resistance. The total pathophysiology, the total understanding has changed. It's not only just beta cell destruction because of insulin resistance, but a lot of other mechanisms involved. And that's why the treatments are changing so rapidly. And it's now individualized care. Mark my word, it's not a single drug you can give to everyone. For example, somebody walks in, I put them on metformin. It's individualized care now. You have to pick and choose your drugs. And diabetes, that's why has become now a specialty on its own, that you have to choose a different drug for every different patient, accordingly tailor-made accordingly to that patient and the patient's needs. So rightly answered, fully endorsed.
Thank you, sir. The next question, can we use SGLT2 inhibitors and DPP4 inhibitors concomitantly at the same time? Yes, of course you can. And in fact, I'd like to add something over here. One SGLT2 related side effect is resultant hyperglucogonemia. And DPP4 inhibition via the incretin effect leads to a reduction in hyperglucogonemia. So adding these two things will be not just additive, it's going to be multiplicative in nature. So that is a very good option to consider. The next is, what are the chances of hyperglycemia while using SGLT2 inhibitors? Dr. Fibber, if you'd like to take that.
Thank you very much. So I think all these novel drugs, especially you have euglycemic agents, you have hypoglycemic agents. So they are mostly euglycemic with very little chance of hypoglycemia, especially if they're used individually. However, when used in combination, there are chances of hypoglycemia. Again, you need to monitor, but when used alone, the chances are minimal.
If I could add to that further, if you were to understand the mechanism of action of an SGLT2 inhibitor, it's not going to throw out glucose via the urine if your blood glucose at that point in time is 80 milligram per deciliter. There is a certain threshold of glycemia after which your SGLT2 inhibitors will prevent glucose reabsorption. And that cutoff level is generally anticipated to be more than 140. Therefore, the risk of hypoglycemia with an SGLT2 inhibitor in normal circumstances is essentially negligible. However, if you're going to combine it with like a sulfonylurea, or if you're adding on insulin to it, then yes, the risk of hypoglycemia will be there. But to blame the SGLT2 inhibitor for that hypoglycemia, I think would be a little unfair. Okay, another very interesting question. When exactly will we start? I'm going to avoid the brand names here, mind you. Let's try to keep it as professional as possible. We're talking about biphasic insulin aspart or I don't know what HR means. My apologies, that's a slightly different term. Okay, if you're asking about pre-mixed insulin analogs, guidelines differ. Once again, we've already mentioned that in the presentation, but just for a repetition, generally speaking, insulin initiation is commenced with a basal insulin. But understanding the progressive nature of diabetes, you are going to need to intensify. Your intensification strategy could be a basal +1, that is adding prandial cover to the largest meal, or you could shift to a twice daily pre-mixed insulin. Once again, you have to think from your patient's perspective. There's no hard and fast rule there. If your patient is motivated, feel free to put them on a basal bolus, but that will be entertaining 4 shots a day, or at least 3 shots a day. If you feel that your patient can't manage that, you want to use a twice daily premix, you'll get excellent results as well. But you need to know to tell them how to monitor their blood glucose levels. You need to encourage regular monitoring. So the takeoff would be after basal therapy, when you're moving to an intensification strategy, you're contemplating a basal +1, then you can opt for either shifting to a premix analog as well. Need to go step by step on those.
I thought it's going to be more questions on hypercalcemia and more questions on stretcher problems, short stretcher. It's all diabetes and diabetes. I'm truly surprised. I thought I'm going to get a lot of, you are going to be bombarded with questions. What about mesimoreline? What about glucagon stimulation? What about ghrelin stimulation? And a lot of questions about stretcher problem and workup. And then an excellent lecture from Dr. Feba about hypercalcemia. And I had a lot of questions. And I'm going to put up all those questions if they are not going to. They're just talking about diabetes and diabetes and diabetes. So
very rightly pointed out, sir. Very rightly pointed out.
Perhaps it's either of the scenarios. Either you were too good in putting up the thing and they're so clear that they don't have any questions. Or
I think let's leave the or out of it, sir.
Okay.
Okay, with your permission, sir, we'll try to round up the diabetes-related questions first so that we can have a further conversation, maybe a tripartite discussion on the endocrinopathies that we discussed as well. It's a very interesting question. I've seen in clinical practice that anyone who is having CKD or DCLD is only maintained on regular insulin, and basal insulin or NPH is totally avoided. Even if the sugars are consistently high, can you please guide about the use of long-acting insulin in such patients, and can we use it in such patients? I think that's a very pertinent clinical question, and my thanks to Dr. Mehek Junaid, I believe, who's asked this question. To be very honest with you, regular insulin and NPH insulin, in my opinion, the only use is poverty. In my clinical practice, I do not use insulin R or NPH insulin. I would prefer analogs, be they rapid acting or basal acting. What you've rightly questioned is, considering in patients with CKD, there's a reduction in creatinine clearance, obviously, and it used to be conceptualized that a regular insulin will act as a basal insulin. Currently, as far as understanding goes, that's no longer the case. Obviously, caution does need to be exercised. There are creatinine cutoffs which you need to consider whilst using a basal insulin, because the duration of action can considerably be prolonged. But essentially speaking, I believe, yes, you should be giving your patients the best possible therapy. A dose reduction can generally be considered. I mean, I wouldn't basalize to an extent of maybe 0.5 units per kg, but I would start with 0.1 to 0.2, build up for target fasting control. I would proceed with a degree of caution, maybe rather than increasing 2 units every time, I'd increase by 1 unit. And I prefer using a rapidly acting analog rather than regular insulin. Mind you, the considerations with NPH and R, especially in our population, are almost impossible to follow. I have yet to see more than 2 to 3% patients who were willing to wait half an hour in between the administration of insulin and their meal. That leads to a dose mismatch. You'll have bouts of hypoglycemia followed by bouts of hyperglycemia. And what Dr. Fibha rightly mentioned during an answer to a question was glycemic variability. You don't want bouts of hypoglycemia. You don't want bouts of hyperglycemia. You're aiming for a good glycemic control within a range that you have set for the patient. Maybe you're not looking for fasting control of around about 100. You'd be happy with 125. Maybe with your random control, you're not looking for less than 40. You'd be happy with 160 to 180. But achieve that control. Don't have a yo-yo effect in which the patient dips into hyperglycemia of 40 and then shoots into a hyperglycemia of 300. Dr. Fibha,
Again, most of these patients, a lot of patients who have CKD end stage or DCLD are going to have very high HbA1c. So they're very far advanced in their diabetes. And again, just giving them regular and hoping that it acts as a basal insulin or NPH. Premixes do a wonderful job. They're not contraindicated. It will depend entirely on the patient's diabetes. A lot of patients are going to just maybe respond to very short-acting insulins, but some of them who have very brittle diabetes, very hard to control diabetes, cannot take medication because of obviously their advanced kidney or liver disease, will require premixes, and they will do very well. And in these patients, again, remember, the risk of hypoglycemia becomes very high. So advising them to take maybe small snacks on a regular basis, along with optimizing the insulin, will lead to eventually leading to your target HbA1c, whatever you've thought for the patient.
Thank you for that summary.
Well, I'd like to add something here. I think you both did a wonderful, beautiful job in explaining. But remember, generally, now all endocrinologists and people who are dealing with diabetes believe that when you are beyond CKD4, you do not want to use basal insulin because the risk of hypoglycemia becomes more. And as you rightly pointed out, we're not aiming for a very tight control. We're aiming for a control, maybe randoms touching up to 200 and the fasting staying below 140. That would be the control I'm going to go for. You're not going to go for a very tight control because it's not going to make any difference in the life or the longevity of life or the quality of life. So what you would do is, perhaps I totally agree, premixes, that means the ultra short acting with obviously NPL in the right proportions given to these patients to achieve a relatively reasonable control. A tight control in these patients would lead to more risk of that has been documented, more mortality, and we don't want that. We want comfort, we want a reasonable control, because they have reached a stage where tighter controls are going to cause damage, but no benefit. So remember, no tighter controls. You want a reasonable control and quality of life. And that can be very well done by premixes.
Thank you so very much, sir, for adding that on. There's another question. Metformin is for insulin sensitivity at a cellular level. Is there any specific measurement to adjust dose if patient is somehow having contraindications with biguanides? To be very honest with you, I don't really fathom the entire question, but I would like to say one thing. Metformin is not necessarily a first-line drug. You have an armamentarium of other drugs to opt for. Yes, metformin does have its benefits. And if there's any reason, I mean, there are a lot of people who have metformin intolerance. We're not going to be making them take it if they're not tolerant of it. As Dr. Fibber rightly pointed out, with all the GI related issues, you have a lot of people who come and tell us, I can't tolerate this drug. And we're not going to force them to take it. I mean, there's no need that metformin must be used in each and every patient, otherwise the world will end tomorrow. I mean, there's no need behind that as well. You've got other drugs, and if I may permit myself to say, safer and drugs with more added benefits to choose from in the entire list. That's why the current algorithm gives you a whole list of drugs, including metformin. You've got SGLT2s, GLP-1s, sulfonylureas, thiazolidinediones, even in some cases bromocriptine. You've got metformin, you've got amylin derivatives, you've got insulin. You can choose whichever one you want to. Just keep your patient first, and I think let's move out of the metformin bubble.
I totally agree with that. And secondly, I think if you recall the Verify trial and a lot of other trials in the same lines as well, will now actually be telling you to use dual therapy rather than single therapy. And that would actually help you to reduce the side effects from any single drug. So you're using lower levels of two drugs to achieve the same glycemic control. The progression of diabetes is also less. But again, if your patient has very advanced liver disease, very advanced kidney disease, you can't really use metformin, and maximizing it to beyond 2 grams really doesn't have any benefit. So,
thank you, Dr. Very rightly pointed out.
And another thing which I want to point out, metformin's main effect is on the liver. It is through the cyclic AMP and PKLMM. So it inhibits the gluconeogenesis. At cellular level, the insulin sensitization effect is minimal. So the main effect, that things have changed. The main effect of metformin is at the liver level. So forget about those olden concepts that it acts at the cellular level to increase the insulin sensitivity. It's the gluconeogenesis which it's inhibiting through the liver, liver. So people may need to understand these things. And Dr.
If I were to make it simpler for our audience as well, metformin simply inhibits hepatic glucose output. If you want to keep it simple. I mean, that's the way it acts for all practical purposes. And even if you're not using it, you're opting for other drugs, as long as you're giving the patient benefit, as long as you're achieving glycemic control, you can opt for other agents.
And I'm endorsing again Dr. Fiba's point of view that adding smaller doses of 2 drugs, that leads to more tighter control and less side effects and combining the beneficial effects of 2 drugs. For example, Dr. Ali highlighted, if you give DPP-4 with SGLT2s, you're addressing 2 problems. That is, you causing weight loss, you're giving cardiovascular, obviously the renal benefits, as well as addressing the hyperglucogonemia by giving DPP-4s. So you see, it's a combination how you combine these drugs, and that would benefit the patient in long term.
Very rightly pointed out, sir. Just before moving to the next, I'd like to highlight that the ACE executive summary mentions that monotherapy in all likelihood will not be successful in the long term. Therefore, the use of combination therapy at an earlier point in the disease is recommended. So endorsing Sir's standpoint and the point that Dr. Fibber rightly pointed out, use dual therapy or combination therapy whenever required, and preferably at an earlier point in time. A nice question, but I'm afraid we're going to have to divert this. How to choose between different pre-mixed insulins. It's very nice, but once again, your own preference comes into account. When you're talking about premixes, are you talking about regular insulin 70/30? Frankly, this might not be the right forum, but I don't use it generally in my patients. Too much of a hassle and too much glycemic variability. You can use a twice daily premix with 30% rapid acting and 70% intermediate acting. You can use a premix with 25% rapid acting and 75% rapid acting. That could be considered more of a brand preference. But since we're not doing any branding here, we're not going to go into that. As part of an intensification strategy, when you need to move into 3 shots a day, then you can use mix 50 morning and the afternoon, regardless of the brand, and either mix 30 or mix 25 at night, essentially, and you will get control equivalent to the basal bolus, essentially, with 3 shots a day, minusing 1 shot from there.
I'd like to add something here, Dr. Fiba and Dr. Ali.
Please,
I
sir.
totally agree that personally, I myself do not use those mixed 30/70s, regular ones. And I'm for the pre-mixed ultra short acting and the NPL mixes. And there are now studies coming up which show that these drugs are superior in long term in terms of not only control of diabetes, but control of complications of diabetes. And obviously, the quality, we believe the quantity is in Allah subhanahu wa ta'ala's hands. But quality and quantity of life has been put forward that these drugs to increase that quantity and quality of life. I'm talking about the ultra short acting and the NPL. So times have changed. If you're thinking about money issues, believe you me, giving them these drugs, that is 30/70, may give them short-term benefit in terms of monetary benefit, but it's going to hamper their quality of life and eventually lead to complications, and our earning hand may be lost. And losing that earning hand means again poverty. So it's a double-edged sword. So on the one hand, you have to look at, obviously, you're adding to the burden of cost, but in the long run, if you think you're adding to quality of life and obviously longevity. So it's a difficult decision sometimes to make in our population. But I tend to use, just like you too, I tend to use rapidly acting, short acting, ultra acting, short acting insulin with NPL mixes rather than 30/70, which leads to a lot of variability.
Thank you, sir. This is a question from the YouTube channel, Dr. Fiba, and that's why I think it will be important to take it. Can you please tell us about a diabetic patient who's having a kidney problem? Diabetic since 15 years. Should they still continue oral anti-diabetics or switch to insulin? I know the data here is slightly limited, but let's have your take.
Obviously, it again depends upon the stage of CKD. So a lot of drugs that you have several options where you can use if this EGFR is more than 45, so maybe up to 60, even using SGLT2 or the use of metformin or the use of DDP4 is safe. But if it is less than that, generally less than 45 or beyond that, insulin would definitely be a safer option. So it depends upon the stage of CKD. And again, we know that SGLT2 inhibitors also inhibit the progression of CKD. So again, but that holds true again if it's more than 45 and not beyond, not less than that.
Taking Dr. Fiba's stance forward, because I'm guessing that this might be a question from a layperson, not necessarily a member of the medical community. We need to understand, as Dr. Fiba rightly pointed out, what's the kidney problem in itself? I mean, is it chronic kidney disease? Has the doctor or the primary treating had, or is it worsening with the course of time? So 15 years of diabetes is a pretty long time. The choice of oral agents would be, you can still consider them, yes, but as we just discussed previously, if the kidney function has gone down extensively, then you might need to move to insulin. Out of the novel agents, however, if you still have a kidney function that's considered at roughly stage 3, then please do add on an SGLT2 inhibitor if you're not taking it already, because that's going to help the kidney and slow down the impairment of kidney function. Dr. This is a very interesting question over here. And this is very rightly pointed out. Some obese patients use metformin to reduce weight, even if they're not diabetic. What's our stance? And shouldn't we only prescribe an obese who is diabetic and pre-diabetic, as metformin has an advantage that it does not cause hypoglycemia, just like SUs do? So do you think it's a good choice for weight loss?
No, I think that's something, that's a very, very practical
Very good question.
And we see a lot of patients actually taking metformin for weight loss. But all data actually suggests that metformin is weight neutral. So it won't really cause weight loss, and at least not significant weight loss. And if you need to lose weight, then obviously you have many other options like SGLT2s or GLP-1, which have a great impact on weight loss. And then you have obviously other drugs which we use entirely only for weight loss.
If I can cut you, the question is for non-diabetics.
For non-diabetics, so yes, definitely not at all.
Not at all. Not at all. Just to give you a little more perspective on this, what's the average weight loss with metformin, if at all?
It's not
the data that you've gotten, absolutely, it's not significant. The data says 0.5 to 0.7 kg.
Which would occur with lifestyle modification.
Which, quite honestly, if you manage to walk half an hour a day, you could probably achieve that in under 2 weeks.
So it's not statistically significant.
Not a nice example, lekin kaddu pe tir marne wali baat hai. There's absolutely not much of a purpose there. Not recommended. Not recommended.
So what about its anti-aging role? And what about
yes, that's a different story. We'll take it for that.
So, since the question was put towards obese individuals without diabetes, we focused over there. But yes, metformin has some wonderful properties as well. And there's lots of data coming in as an anti-cancer modality, as an anti-aging modality, acting on your sirtuins, etc., etc. But at this point in time, the FDA hasn't given metformin a label saying that this is a wonder drug, take it for each and every indication on the planet. So off-label, perhaps if you actually believe that it's going to give you some benefit, feel free to take it. But for a weight loss perspective, thinking that you're going to have clinically significant weight loss with metformin, you're living in a fool's paradise. Another question. Any data on use of SGLT2s in type 1 diabetes?
Okay, again, that's a very interesting question. We have a lot of emerging data using both DAPA and empagliflozin in type 1 diabetes. But again, that would not be alone. It's in very limited trial settings. Remember, there's SGLT2 also increase the risk of diabetic ketoacidosis. So in our population, we have to be very, very cautious. There are a lot of studies coming up, but again, it's not that you can take the patient off insulin, put them on an SGLT2. And so for now, I think at least I'm not using them in my type 1 diabetics.
Adding on to what Dr. Fibber very rightly pointed out, the mainstay of type 1 diabetes was and always will be insulin therapy, because the primary defect is in insulin production. The fact that SGLT2 inhibitors act independent of insulin does give a glimmer of hope of using these in type 1s as well, essentially for maybe their cardiovascular and renoprotective effects as well. But trial data is still limited. We'll have to see what happens with the course of time. There are trials, but they're not openly labeled to be used in type 1 diabetics just as yet. So if you would decide to do so, you're a practicing physician, you could think about it, but there's no indication to do so just as yet. Not in the guidelines.
They haven't been approved in type 1
they haven't
diabetes.
approved just as yet. Oh, finally. Now, this, Dr. Fibber, is something that you're going to enjoy. This is a question with regards to hypercalcemia.
Oh, finally.
So I give you a bit of peace of mind as well. We're finally getting questions out of diabetes.
My God.
So I'm going to take this question. In patients with rheumatoid arthritis and hypercalcemia, the underlying cause is primary hyperparathyroidism because of an adenoma. I believe this is a case scenario. She is an elderly lady around about 60, hardly weighs 38 kg, thin, lean, unfit for surgery, according to the anesthesia department, because of rheumatoid arthritis. Have been tried with calcium mimetic, Mimsipar, 120 milligram doses has been given, and the bisphosphonates given twice so far, but the calcium is still around 11 and 12. What could be the other options in such patients? We do not have denosumab available. What could be the alternatives?
So the first thing I think that if the patient is a diagnosed case of hyperparathyroidism, we know that there are indications for going for parathyroid surgery. Now, parathyroid surgery is not a very, very invasive surgery. Remember that. It's a minimally invasive surgery. We have newer techniques. So the first thing to decide is whether the patient is a candidate for surgery. So the indications for surgeries are, again, if the patient is symptomatic, and if the patient, like, for instance, has had pancreatitis or renal stones or any other issues, and if it's asymptomatic, then if the age is less than 50, if the calcium is more than 1 above normal, which seems to be the case in this patient. Number 3, if there is the T score is of more than 2.5, and if the eGFR is less than 60. If the patient is fulfilling any one of these criteria, then the patient should undergo surgery. So although the patient might be frail because of rheumatoid arthritis, but I think not doing surgery, because it's a minimally invasive surgery, will have and might have long-term consequences, especially pertaining to renal deterioration. And rheumatoid arthritis itself is a risk factor for osteoporosis. So you will actually be adding fuel to the fire. And I don't think medical therapy would be very helpful for a very, very long time, because these are just generally bridging therapies. And if the patient needs a definitive treatment, the patient does need a definitive treatment.
Very rightly pointed out. And although I'm not an anesthetist, but I'd like to add on, our colleagues in the anesthesia department are a little scared when undertaking intubation for patients with rheumatoid arthritis because of the risk of the atlantoaxial subluxation. So if extra care is taken whilst managing this patient, you can contemplate other modalities of anesthesia. I think this case can be undertaken, but a multidisciplinary approach would be required to prep the patient properly in advance, leaving her with a parathyroid adenoma, trying just for medical therapy, as Dr. rightly pointed out, it's just bridging. You're not going to be able to achieve a target in the long run. So a conclusive treatment would be surgery. You just need to get your anesthesia colleagues convinced. I've heard of them performing cases or putting patients under with even more risks. So understand the risk-benefit aspect of things, take care whilst intubating, and get a competent anesthetist on board. So what's your take?
And with you two doing the job, I don't think I need to add much on. Rather, yes, minimally invasive surgery is the answer rather than waiting. I want to change this calcimimetic thing. They're not calcimimetics. They are calcium receptor sensitizers, calcium sensing receptor sensitizers. They're no longer called calcimimetics. For example, the Cinacalcet is not a calcimimetic. It's a calcium receptor sensitizing drug. So what it does is it sensitizes the calcium sensing receptor to the available calcium, and the PTH is inhibited. The secretion of the PTH is inhibited. So they are no longer called calcimimetics. So I wanted to change that. So please do not call them calcimimetics now. Secondly, in this case, the answer is very straightforward. Yes, what Dr. Ali highlighted, the risks are there, multidisciplinary approach, but the answer is minimally invasive surgery after good, obviously, fluorocholine scan. Fluorocholine scans are not done here, but we can use a sestamibi scan and localize and then approach the patient and do the surgery. And that would change the quality of life of the patient.
Are we sure? If we want to talk about it, Although the next question that we have in front of us is slightly beyond it's not related in its entirety, it's slightly beyond the scope of today's discussion, but just to add on here, what to offer to a patient with celiac disease having bad osteoporosis? Should we just follow gluten-free diet or offer bisphosphonates?
I think that's straightforward, doctor.
I think it's pretty straightforward. I mean, if a patient has osteoporosis, you are going to use calcium, you're going to use vitamin D, you are going to use bisphosphonate therapy. Celiac disease has led to a degree of malabsorption, I'm sure, at some point in time, but the treatment modality will involve using bisphosphonate therapy.
And with the drug like Evenity coming in, which are changing the scenario, which means we can make new bone now, obviously things will change. So it's not only bisphosphonates, we'll be giving obviously anti-sclerostin drugs, and these anti-sclerostin drugs have been approved as treatment modality as anabolic bone forming drugs. So in a celiac disease patient, gluten-free diet, calcium, vitamin D, with obviously now an anti-sclerostin drug. So that would lead to new bone formation. And obviously as the celiac disease occurs in majority of time in young people, not that it doesn't occur in old age, but majority of patients are young. So you want their bones to be stronger again. So we can use teriparatide or you can use anti-sclerostin drugs.
And I believe that brings us to the conclusion of the questions that we had in the chat box. So would you give your final comments prior to wrapping up the session?
I think it was a brilliant session. You two did a brilliant job. And you don't need anybody to sit there, and you two can get along very well answering all the questions. And I really thoroughly enjoyed the presentations given by both of you. They were very precise, to the point, and covered almost everything. And it's not that you two are sitting here, believe you me, having attended many sessions, I was glued to the screen and listening to every word which was being said, enjoying it and understanding it. And really, I think we should have more of these sessions. And I'll vote for both of you to be there, because you complement each other. You really complement each other. And you make it sound like that it's not a very scientific session. It's a chat which is going on with two colleagues who are adding on to each other's obviously answers, and makes it sound wonderful. And my sincere congratulations and compliments to both of you. And I hope we will have more of these sessions.
Thank you very much, sir.
Thank you, sir. It would be unfair not to thank our Farmivo colleagues who've brought us all together and provided this forum. And inshallah al-Aziz, hopefully the Endocrine Training Forum will continue. This was the first of one of these sessions from the two of us, and hopefully we'll be having many more to come in the future. So with that point, we'll be signing off. Thank you so very much for your time. Jazakallah khair. Assalamu alaikum.
In last, thank you so very much, Professor Dr. Rauf Niazi. It's a very, very informative session throughout the Pakistan. And this is the just slide which I shared from the comment box of our respected participant, which really pay thanks, especially Professor Dr. Rauf Niazi Saab and Dr. Ali Arif and Dr. Fiba Sayyed. We really thankful to Dr. Salim, Dr. Adil Aurangzeb, Dr. Hana, Dr. Shahjahan, Dr. Adil Aurangzeb again, Iffat Bukhari, Dr. Sara Shah, Dr. Shaukat Bukhari, and across the Pakistan. And you can see Dr. Saab के यहाँ JPMC वार्ड में एक दमगट्टा लगा हुआ है डॉक्टर्स का, जो आपके प्रेजेंटेशंस को सुन रहे हैं, आपके discussions को देख रहे हैं, and we really thankful to you once again from the platform of Endocrine Training from Forum and platform of Farmivo. Thank you so very much. Inshallah, in future हम इसे continue रखेंगे. Thank you so very much, sir.